It's really an honor and a delight to be here. Thank you so much to the organizers for planning this meeting and for inviting me to talk. Today, I'm going to focus on talking about how we're using large neuroimaging data sets to model stroke rehabilitation outcomes. Before I start, I want to thank our Enigma Stroke Recovery members, without whom none of this work would be possible. So this is truly collaborative. People are contributing data that they're collecting for their own studies. They're working together, and that's part of the 300, but I think there's a lot of power in bringing people in the rehab field together, which I think is also the theme of this conference. So I wanted to highlight these questions front and center because I was asked to explicitly address them. And I will be talking about them throughout my talk. I've actually structured my talk to address them, although it's in a nonlinear fashion. So hopefully that's okay for you guys. I'm actually going to start with the second question, which is how has computational modeling supported your work? So, as Nicholas said in my introduction, I am an occupational therapist and a neuroscientist. As an occupational therapist, though, the reason I got into research is because when I saw patients, I didn't have confidence that I was giving them the best treatment for them at that time. And I knew that there's a critical window for them to recover. And I had a lot of doubts about if I was doing everything that I could to help them recover to their full potential. At the same time, I had patients that were sometimes not recovering no matter what I did. And I tried all sorts of things. And I really wanted to go into research because one, I wanted some confidence. I wanted some data-driven evidence that I was giving them the best care at the time. And two, I wanted to be able to create things for people who didn't respond to anything at all. So the overall goal of my whole research, and the reason I am a researcher now, is to optimize rehabilitation for people after stroke to help them achieve meaningful recovery. And I also want to note that to me, recovery is so that they can engage in meaningful activities in their daily lives. And so sometimes that looks like gaining 20 degrees of freedom in their upper extremity. Sometimes that doesn't, and that's totally fine for me as well. I think I want to be able to support people, whether it's regaining motor function or getting jobs or being able to interact with their loved ones in a normal way again. My approach has been twofold. So one is to try to identify who might respond best to which treatments at what times. And I think that's a goal for many people in this room. Realistically speaking, I think we're more at this interim stage of identifying biomarkers that are associated with sensory motor outcomes so that we can then try to correlate that with response to treatment. And then two is trying to develop treatments for those who don't respond to anything at all. And today I'm actually just going to focus on this small part of the program, which is trying to identify those predictors that are associated with sensory motor outcomes. Well, the first question, though, going back, was what are challenges in neurorehabilitation? And so to me, one of the big challenges is that stroke recovery during rehabilitation is extremely variable. So compared to the acute phase where you have a few options, you can do a surgical intervention, you can provide a drug. At the rehab phase, it's so variable. And it's not just, what their brain looks like or what their initial motor patterns look like, but it's also about their social support, about their motivation, about their mood, about their sleep, about so many variables. And so I think one size doesn't fit all. And personally, I think to be a little bit provocative, I think the traditional model of clinical trials to say, does this treatment work or does this treatment work better than standard of care? Sometimes I don't know that that's answering the questions that we need for our patients. What we really want to know is who does this treatment work for? When will it be the most effective for someone? And where should we target for this person? Because with every treatment, I feel like it works for some people. So trying to identify that is really the key. And I think that brings us to the idea of personalized, data-driven precision rehabilitation. And I know that's what a lot of people here are interested in. So the second part of the first question was how can computational model help with this? I think ideally a computational model would predict the optimal rehabilitation treatment, timing, and dosing, so that clinicians, such as myself, if I were to see a patient, could have confidence that we're doing the best thing for a patient at any given time. And when we test out new treatments or new strategies, we have an idea of who this is really going to be beneficial for. The data that are needed to support this, though, are no small task. And I think that Nicholas and Dave and James covered this in their pre-conference session. So mostly you need data and a lot of it. So computational models thrive on a lot of data that has high variance, that captures the variance of the population that you want to predict for in a representative array of critical input variables or predictors, and to predict carefully defined outcomes. So I think, we talk generally about, wouldn't it be nice to have precision rehabilitation? But in the end, you actually have to define all of these things, and there's so many that you can choose from. And so that's why I think in the long term, the kind of moonshot for me would be to have computational models that could augment but not replace clinical decision making. And I think that's very important to note, because in the end, I mean, maybe in 100 years or maybe 10 years, the way that technology is advancing, we could have models that could take in 1,000 different input variables to predict, 1 or 2 critical outcomes. But right now, models are limited to how many predictors you can put in them. And we're also limited in how we can characterize those predictors. So as a therapist, when I see a patient, like I said, I also think about when they come in for a treatment session, not just like what treatment theoretically would be best for them, but also what's their mood that day, what's their attitude, how are they feeling, what's their social support like, what else is going on in their life, all the comorbidities that they may be experiencing. And so I think there's all of those variables that we don't usually capture in models that are also important for the end clinical decision. So for me personally, what I've been doing to try to get towards this type of model is first trying to get big data. I would say maybe bigger data. I appreciate anyone who laughed at that. Thank you. So I say bigger data because, depending on what field you're coming from, big data could be like millions and billions and trillions of data points. For us in rehab, I think it's just getting bigger data sets than we're used to working with. So I'll talk about that in a second. I tried to get data that has some variance, which I'll talk about in some variables. And like I mentioned before, it was a limited subset of variables and to predict an outcome. And in my case, I've been working on predicting sensory motor performance. So in terms of what variables or predictors I've been looking at, I think there's 2 promising predictors of sensory motor outcomes that have come up again and again, and those are early sensory motor behavior, so how the patient looks right after they've had the stroke or within the first week, and brain imaging that quantifies the impact of the lesion on the brain. And so those are 2 that I've been really interested in order to predict long-term outcomes and eventually response to treatments. However, generating a high resolution neuroimaging is not a commonly collected component of routine stroke rehabilitation. So getting a large data set of this with rehabilitation outcomes has been very challenging. One way that we approach this is by partnering with Dr. Paul Thompson, who's here at USC, and he founded the Enigma Center for Worldwide Medicine, Imaging, and Genomics. It's essentially a collaborative way to get big data sets on all different topics. What happens is people collect data for their own studies, and then they collaborate and contribute that data for retrospective meta-analyses. And so I just want to point out that there's over 50 working groups in Enigma. Here's stroke. Here we are. So we're just one of many in this universe. But we are, I think, one of the main rehab focused groups here. So it is an approach. If you work on a different disorder that's not listed here, you could also start an Enigma group if you wanted. For Enigma Stroke Recovery, I am the chair of this group. We have over 100 researchers across 15 countries. We have thousands of data points at this point. So we have what I call research grade or high quality imaging. We also have a lot of clinical imaging that we're starting to work with now because that is routinely collected as part of patient care. I'm going to briefly go over this, but we basically have worked for many, many years in order to both gather the data set and then make sense of it. I think, in computational modeling, the focus is on the modeling, but there is so much when it comes to rehab and the messiness of the data that has to be done to get the data to a point that you can model on it. And so that's been years of my life. We now have many neuroinformatics pipelines. We have code that we've shared. We've tested a lot of methods for how to not only receive and harmonize data from different sites, from different studies that are collecting data for different aims, but also how to glean the most important metrics out of that data. However, once we have that clean data set, then we can start to apply computational modeling to address many different problems. I categorize them as technical, so things like segmenting lesions with automated methods using computer vision, extracting regions of interest from stroke brains. These are things that we have to do because we have so much data, we can't necessarily do it manually, but once we've done it, we hope that it benefits people with big data or small data. These methods should ideally benefit anyone with any size data. We also can use it to identify complex patterns and answer scientific questions, which I'll focus on for the remainder of this talk. And then the long-term goal of having such large data sets is being able to do clinical predictions with them. And that is something that I think we're working on now, but we're not quite ready to share the results yet. So like I said, I'm just going to focus on the scientific aspect, and I'm really just going to hone in on one study that we've been working on lately. So scientifically, we have been using this large data set to look at the relationship between stroke outcomes and the integrity of residual motor architecture. So post-stroke sensory motor deficits are often obviously associated with damage to the brain, whether directly by the lesion or indirectly through diaskesis. So you might see that as changes in the functional networks after the brain has a lesion, or changes in even structural networks. A lot of attention has been given in our research in our field to focal measures that quantify lesion damage to specific structures. The most well-known is cortical spinal tract lesion load. So it's how much the lesion impacts the cortical spinal tract. And that's a very strong predictor of how likely someone is to recover. But I think outcomes and recovery ultimately rely not on what's been damaged, but on what's left after you have a stroke. And so what we've been doing with our big data set is looking at these relationships, in part because they are more subtle, and I think they require larger data and more power to be able to detect. So for instance, using this large data approach, we looked at 828 people with stroke across 28 cohorts. And we found that the integrity of non-lesioned brain regions in spared deep gray nuclei, such as the thalamus, the putamen, and the nucleus accumbens, are associated with sensory motor outcomes, and that these relationships differ across time, so in early versus chronic stroke. And they also differ when you're looking at a measure of sensory motor impairment versus function. So specifically, we found only relationships between these deep gray nuclei as predictors of sensory motor impairment, but not of sensory motor function, so things like the Wolf motor test. And we think that that is in part because function relies on regions of the brain, on like more distributed networks across the brain versus more primitive structures. In a second study, we also showed that non-lesion hippocampal volume is also associated with sensory motor outcomes. And this was important to us because the hippocampus is a structure that's not often related to sensory motor outcomes. It's usually thought of in relation to cognition or dementia. And this, for us, creates a little bit of a bridge for why post-stroke we may see cognitive and sensory motor deficits, and why there's a relationship between cognitive and motor interaction in stroke. But the study that I'll focus on today is one that we've been working on in brain age. And so I think beyond these specific regions, the global health of the whole brain should also impact outcomes. Brain age is a concept that's been widely studied in Alzheimer's and aging literature, but not as much in stroke. And it's basically a prediction of the age based on biological data from the brain. So how many people have seen this app or tried this app? No, you can Google it. It's like what is it called? Like Face Age app or something. You basically give the computer your picture and it predicts how old you are based on your facial features. So in this case, it predicts that this poor man is 65 years old, but George Washington is only 56, presumably because he has a few more wrinkles and a balder head. But the idea is that you can train machine learning algorithms to recognize and then predict outcomes. In this case, it's age. With brain age, it's a similar concept, but instead of feeding it a picture of somebody's face, you feed it a brain image for them. And the machine learning algorithm identifies and quantifies what the predicted age of that person is based on the features of their brain, like the thickness of their cortical regions and things like that. Higher brain age is thought to reflect atrophy and be correlated with all sorts of diseases, which is why it's so interesting. It seems to be somewhat disease agnostic in that it's corresponding to traumatic brain injury, schizophrenia, depression, Alzheimer's, et cetera, et cetera. And the idea is essentially that at some point you either have a slow movement off of a healthy aging trajectory, or you have a sharp movement, which is shown in the yellow line here. And so for us, so the brain age derivation is essentially you take, we calculate what we call brain pad, which is brain predicted age difference. It's the predicted age given by the algorithm minus the chronological age. So for instance, if your chronological age, if you are 60 years old, but your predicted age is 70, you have a higher brain pad and essentially your brain looks 10 years older than you actually are. I'm sure for everyone in this room, your brains look younger than you actually are. Don't worry. But this has become a very interesting metric and has been correlated to many different behavioral outcomes. So for us, we wanted to model this relationship. Is there a relationship between global brain health as indexed by brain pad and stroke outcomes? We had a few hypotheses, and we wanted to specifically understand how a global measure like BrainPad may interact with a more focal traditional measure like CST lesion load, and how that might impact outcomes. To do this, we did a mediation analysis, and we specifically hypothesized that more lesion damage, as indexed by cortical spinal tract lesion load, should be related to a higher BrainPad. That is, when there's focal damage, that should also have downstream effects on the entire brain. That higher BrainPad should be associated with worse outcomes. So the less, I guess, the way I think of it is the less resources you have, the worse the outcome and recovery is. And then 3 is that BrainPad as a global measure should actually mediate the impact of focal injury. We think that this maybe explains some of the variance that has been regularly attributed to focal measures. And then the assumption that we're making, because we are only using cross-sectional data, is that higher BrainPad is likely due to post-stroke atrophy. And so the way that we test that with cross-sectional data is to look also, we look at the whole data set, but then we also look at just people who are in the chronic phase of stroke, because they should have had more time for this to impact them, as well as just the ipsilesional hemisphere, because the largest effect should happen nearest to the lesion. For this study, we looked at 963 individuals with stroke from 28 cohorts. We had high resolution T1 weighted MRIs and sensory motor scores. We calculated brain age using a ridge regression model that was trained on over 4,000 healthy controls, uses 153 features of interest across the whole brain, which are shown in the image here. And one of the reasons we use this model is because it's publicly available. So a theme in my research is reproducibility and trying to share as much as we can. And so this is a model that you could go online and you could run your data through if you wanted to see if you also have brain age relationships. We also calculated lesion damage. So we looked both at lesion volume and at cortical spinal tract lesion load. We calculated that using a tool called PALS in my lab, which is also freely available. And then we did a mediation analysis using a 3-step segmentation approach with significance testing with bootstrapping. We had fixed effects of age, sex, lesion volume, and intracranial volume, and a random effective cohort because it was a multi-cohort study. So what we found is that in the full sample, there was only I call it a non-significant relationship where BrainPad mediated 4% of the relationship between cortical spinal tract lesion load and sensory motor outcomes. But then when we drilled down to just the ipsilesional chronic sample, which is where we thought we should see more, a stronger relationship, we saw that BrainPad actually mediates 15% of the relationship. And to just give you an idea of what each of these is, so cortical spinal tract lesion load, essentially the larger the cortical spinal tract lesion load is, the higher BrainPad is, or the worse the overall brain. The higher the BrainPad is, sorry, this clicker is less sensitive. The higher the BrainPad is, the worse the sensory motor outcomes are. And then BrainPad actually mediates or explains some of the variance that would otherwise be attributed to cortical spinal tract lesion load. And so to us, what this suggests is that BrainPad is an important measure of outcomes as well that we need to consider. I then started thinking about brain resilience, and to be honest, it's because a giant tree fell in front of our house and almost fell on our house. And it started making me wonder, we had like this huge windstorm in Altadena, which you barely missed, by the way, by just 1 or 2 days. There's a huge windstorm. We have giant trees where we live, and most of them stood, but one of them fell. And it just made me think about like, why that one? You know, like why can there be so many, the same insult to the forest and only one falls? And I think that relates to this question that I also think about is why can 2 people have the same amount of lesion damage, but such widely different outcomes? And I started thinking about resilience, and I was looking into the literature, what exists. And it turns out in aging, there's a lot of literature on super agers. These are people that they say show cognitive resilience despite normal aging processes. So the brains look the same, but they somehow manage to have resilience and have better cognitive performance than other people. Thank you. Okay. So the hypothesis we asked is, can structural brain resilience to focal damage dissociate people with good versus poor outcomes? So this is slightly different from the cognitive definition in that it's, when you have a brain insult like a lesion, some people show better resilience, some people show worse resilience. And I think that that can be quantified, or that may be in part what BrainPad quantifies. So I define structural brain resilience as lower BrainPad or less whole brain atrophy, despite the same amount of lesion damage. I think that this clicker may be slowly running out of batteries. Oh, thank you. Okay. Okay. So to do this, we split the data into two groups. We had people with good outcomes versus poor outcomes. We looked at propensity score matching. And so we matched the groups based on lesion damage. And so they had equal amounts of lesion damage, both CST lesion load and lesion volume. And then we used logistic regression to try to see if BrainPad could predict people in the good group versus the poor outcomes group. I feel like I'm like a remote control, for TV. Anyways, we found that greater brain resilience explains why people have better outcomes despite similar amounts of lesion damage. And that this is essentially what it looks like. So people with triangles are those with better outcomes. People with circles are those with worse outcomes. And you can see the matched pairs. We just demonstrated a few with the dotted gray lines. And the people with better outcomes tend to have lower brain pad. And the people with worse outcomes tend to have higher brain pad. And we define that difference as brain resilience or conversely brain vulnerability. Okay, so overall, I think hopefully we've shown a little bit that with this computational approach, we can identify that structural integrity of both whole brain and specific spared regions are associated with sensory-motor outcomes. That markers of global brain health modify the impact of focal lesion damage on outcomes, which I think underscores a key role for markers of biological aging. And then our upcoming work aims to examine the impact of these metrics on recovery, both longitudinally and to translate these findings into the clinic, first to predict outcomes and then to predict treatment response. And we're doing that actually now with clinical data, which I think is important for making this actually viable. Okay, so these are my opportunities and challenges. But I have a little bit, this is a little bit of a challenge in itself to get the clicker to work. I'm going to try to. This is like reinforcement learning to some degree, right? I'm going to get it. Okay. Okay, so challenges, I think we need to understand better what can or can't be accurately modeled and what predictors are needed. We also need the data, like I mentioned before, especially coordinated longitudinal large data sets. And then we need more opportunities like this to share across different languages. For opportunities, I think a great opportunity in our field is data and code sharing, which I'm not going to talk about. I'm going to go through very quickly, but I think it improves the reproducibility of the field and reduces research waste. And standardizing it can help to enable a shared language between disciplines. Okay. Oh, thank you. Which one? Okay, this is way better. Thank you. I feel like my force is going to be extra strong though. Okay. We have shared data, so if you're interested in data, this is 1,271 stroke MRIs with manually segmented lesion masks. We also created public lesion segmentation challenges with it. We've also shared code. All of these links are here, and I'll also share them on Twitter, or whatever venue you guys want me to share it on. Also, I wanted to note just a quick plug for those who are on the less computational side. I think even for me, coming to a conference that's focused on computational modeling can be a little bit intimidating because I don't feel that that's my main background. So for those who are from a different side, like a clinical background, I want to highlight our new research education program called Repro Rehab. It's funded by the NIH, and the goal is to teach rehab researchers without any computational background, computational skills. So we teach you beginning programming, how to use Python, MATLAB, R, also principles of reproducible research. And we also made all of our materials freely available on YouTube and GitHub. So it's there. We just finished we're wrapping up our first cohort. The next one will start this fall. So join us. And you can also ask us about data sharing. And for those looking for data or courses to get started with, we also created what we call Repro Rehab DB, which stands for database. It is a searchable database that we have manually curated with 171 courses on data science, 51 open source data sets, and it is rateable. So you can log in, and if you start using a data set and it's awful, you can rate it a 1-star and say, don't use this, don't waste your time. You can also add your own data set or course, which is great, so that if you have things you'd like to share with the community, we ask you put it here. Okay, thank you so much for your time and attention.
Very much. Great talk, and they probably for the first talk. We have 5 minutes for questions.
Specific brain pad metric than the biology.
Yes, it's a great question. So this is an area that we recognize as a limitation of this. So this is the first pass at looking at this. We only use cross-sectional data because that's what we have. Oh, yes. So my understanding of the question, do you want to repeat the question? Okay. All right. My understanding of the question is, can you talk about the causality? Essentially, is the change in brain pad due to stroke, or is it something that was pre-existing before the stroke? Is that right? Okay, great. So the way that we get at it in our cross-sectional data set is that we divided people into early after stroke, so within the first 6 weeks, and then later after stroke. And we see stronger relationships later after stroke. So essentially, if brain pad was just a premorbid marker, then you would expect to see the same strength of the relationship in early stroke as in chronic stroke. But because you see it in chronic stroke, we think that I don't at all discount that there could be an effective brain pad right after stroke that is premorbid. And I think it should be very interesting. But I think that there's an additive or greater effect after the stroke because there is some long-term dysgenesis, or sorry, long-term degeneration that occurs. Thank you. Yes.
Young people with healthy brains differ greatly in their cognitive intelligence and their sensory motor dexterity. So you might imagine that when they get a stroke, they are going to differ greatly in whether they fall off the cliff for activities of daily living. Have you tried looking at some of these underlying cognitive and dexterity factors that might have existed pre-stroke?
It's a great question. So I'll tell you, my moonshot idea was to somehow scan everybody and then wait for people to get strokes. I think that's the idea, right? It's like you somehow know already, because the hardest thing about this field is that you don't have a baseline. You don't have a true baseline. The closest that we can get is like the first 72 hours after stroke, but during that time period, we're not getting high resolution imaging because they have clinical imaging so that they can make clinical decisions that are going to save their lives. But I think to your point about dexterity and all these other factors, I think there are so many factors that we are not considering in this model that we, at the moment, this also goes to the need for harmonized coordinated data sets. We don't have that data across everyone. We do have some data sets. Some individual groups collect both cognition and motor scores or dexterity or proprioception or other things like that. But we don't have it in large numbers across the whole data set. So it's really hard to ask. But I think that's a great point and great question. Thank you. Yes. The question is, does rehab impact brain pad? Great question. We don't know, but I think it's one that we can definitely look at. I believe that ours is the first study to look at brain pad in rehab in general. So there's so many questions that we're interested in, and we're not only interested now to look at does rehab overall, like amount of rehab, impact brain pad, but also does brain pad influence if somebody's going to respond to a certain type of treatment? So those are some questions that are coming up. Thank you. Yes.
So since you're dealing with big data, then one challenge is the large biological variability that you're dealing with. So I was wondering how your computational approach is able to not confuse by the variability, but it's able to capture the pattern. So just at the conceptual level.
I'm not sure I understand what you're asking.
So since you're getting data from a large number of people,
Yes.
then there is a pattern that is common to all people. This is what you're trying to capture, plus minus noise. So how your algorithms or computational approach is able to not get confused by the noise and arrive at the just in the at the conceptual level.
I see. Okay, so I think that, thank you for that great question. I actually think that the benefit of the big data is that there is so much variance and that it will cluster into different subgroups versus having like one pattern. I think that noise is actually extremely variable or extremely valuable because it tells us about the patients. that we are treating. And I don't think we want to get rid of that noise necessarily. I think what we want to do is identify the clusters that fall naturally together and then try to identify treatments or approaches for each of those clusters. Thank you.
Great talk,
Thank you.
Lee. I'm interested in the outcome variables,
Mm.
and it seems to me this is a real challenge that we have in neurorehabilitation. You kind of sort of glossed over that a bit, but you commented early on that this is a challenge. How do we address that?
Great question. Thank you for giving me time to talk about it. So I had it, but I took it out for time. So in Enigma, when we started, we just started getting data, whatever data people had. When I amassed the first kind of large data set, I think we had 1,000 subjects and we had 150 outcome measures that people had collected. There were so many outcome measures. One of the things that has actually been very helpful is the stroke rehabilitation and recovery roundtables. They've been putting out papers since about 2017 on recommendations for measuring cognition, measuring sensory motor outcomes, et cetera. Since those papers came out, I think there's like a 2-year delay. And then we started getting cohorts with exactly the same outcomes. And that has been amazing. So now I think they recommended the Fuglemeyer, the NIH stroke scale, the Wolf motor function test, or ARAT, and then stroke impact scale, something like that. And I think people have been putting those into their grants because those are the recommendations, and they've been collecting them and then sharing that data. And that's one way that we've been able to harmonize the data a lot better. So recommendations like that, having some harmonized recommendations. And then what we do with our data set that I glossed over is we just take the average, we call it a normed motor score. We take the maximum possible score out of 100. And so we just scale everything by that. And then we also look at specific scales. So for instance, when I talk about sensory motor impairment, we only use the Fuglemeyer, and that's present in about half of our data. So that's kind of how we've started to approach it. But I think the more that consensus recommendations come out and the more people are willing to follow them, the better it will be for the field. Yeah, thank you.